Oh, yeah. So I think the previous session somehow ended somewhere. So yeah, so we are saying that besides what I've already indicated as principles, we need to check for um, the completeness and the eligible. You need to see clearly what has been prescribed. And the other thing that I also want to take note that us as nurses and midwives, nurse midwives, we need to be knowledgeable. We need to be knowledgeable. One thing that I've I don't know in other countries, one thing that I've noticed that we teach this course to our pre-service students, and they really find it to be difficult to conceptualize. And right now, as I speak, I'm attending a session where we want to upload some of this content to become so that they're able to access. I think the beauty is if you don't have time, you're able to play back and just listen through. So we need to have this general knowledge. We need to study as much as we can. We need to compare the drug card with drug label 3 times at a time whenever you are trying to give this medication. Very, very critical. Okay, so we also need to know the purpose. For example, what is the purpose of oxytocin? Okay, what are the expected outcomes? What would be the outcome of me giving oxytocin that is beyond? Of course, we know. If, for example, this is in an infusion, we even know that the ultimate thing that would come after is that this uterus may rupture. So, again, the other thing that is critical as a principle, do not leave medication unattended to. Do not leave medication unattended to. Even the emergency trolley. That's the reason why it is put at the midwife's bay nearby. It is for obvious reason. There should be an eye. If possible, let it be lockable. Okay, so hence us focusing on controlled drugs. Okay, so some medication needs to be checked by another nurse. Okay, um, and apart from this, the other important thing that when you are administering intramuscular injections, do not give more than 5 meals at one side. Important to remember. If you're not so sure of what you are doing, it's always important to consult. Could be a supervisor, a senior nurse, or someone who is more knowledgeable, so that we are always falling within the obvious correct limits. Do not administer medications calculated by someone else except the pharmacist or yourself. Very important. This time around, I took my son, he had tonsillitis, to the facility, to the clinic. Now, this nurse, I was so sure that the calculations were wrong. I said, no, you can't give my son that drug. He may just collapse. I went to do my own calculations and he gave the nurse to say, this is a dose that you need to give. So do not administer medication. Someone has withdrawn this drug and they hand it over in a syringe. You don't even know what is in a syringe, and you proceed to give this drug. Some of these drugs, they have similar colors. You don't even know. Someone hands you over on a lead or on a receiver. Give this medication for me. You don't even know what is contained. So please, on this one, a principle of drug administration, never, never allow someone to um, to use you to administer a drug that they themselves could have administered. All right. I think this is another obvious thing. Okay. Any questions? Are we clear up to this end?
Everything is still clear on my side.
Everything is
Also
what?
on my side, yes, it is clear.
Oh, great. Please, if you have a question, you can easily drop in the chat so that we're able to pick it. So we can then move on a bit. Okay. So let's go to dosages and strains of drugs and solutions. We know that the sources of our medicines are plants and roots. That's why our parents, I think, are so passionate about this. And at times we want to just cast a blind eye on things that are obviously coming from our roots. Maybe just a question. Do you sometimes experience Annette? Do you experience sometimes a these mothers coming to labor ward, they could have taken something apart from what you could have loved them to take? Do they come with herbs at your facility?
It's very common here in Lesotho. They
Ah,
call it the pizza.
uh-huh.
Yes, and sometimes you'll find that some drugs that they take, they are very high in oxytocin.
Uh-huh.
So they end up having a lot of contractions.
Yeah. And how have you managed that?
Yes,
We had to.
even here in Rwanda.
Mm.
It's like we are talking at the same time. Let me give Annette chance to talk.
And no, you can continue then. She can come through.
Okay, we experienced that that these herbs were causing a lot of maternal deaths and neonatal deaths. So,
Mm.
as the country, we strengthened the health education to the communities. It is still there, but it is very rare now. And they also used to use mercury, and now that the mercury has been phased out in the country, it's like there is reduction. Thank you.
So what were they using mercury for?
They call it the pizza is what they have been given by the mother-in-laws. They
Mm.
are saying if they have taken the mercury, it will assist the labor to start.
I see. Thank you for sharing your experience. Yes, Annette, you are muted.
Was also saying that we also have those herbal medications that
Mm.
are given by these old mothers
Mm.
in order to stimulate the contraction. That's what they intend to. So
Yeah. Thank you so much, also, quite for sharing that experience. So one thing that okay. So one thing that is so common, I think, in both submissions, that yes, we acknowledge that we have these medications, herbal medications available. But I think one thing that, for me, yes, we have not done very well is, I think, creating an opportunity out of these. Because if they enhance contractions, then definitely there is oxytocin that can be regulated. But at the end of the day, I think it's irrational use. And they don't care. I know even back here, when you just see this woman visiting this pregnant mother with a flask, a container, just know there is something. From nowhere, after she just sips one cup, this one goes into uncontrollable contractions. So these are critical sources of medicines, plants and roots, and this we can't run away from. The other source of medication and medicines should is animal tissues, the mods. Okay, this is coming from mushrooms, a laboratory. Sometimes these are synthetic, man-made. So all these are potent sources of medicines. Now, the reason why we are trying to just plow back and get this understanding is just to build a foundation to what we'll be discussing, I think, tomorrow or the other day. Then, what are the general purposes of drugs or medicines? This word drug and medicine is used synonymously. And in the previous session, we said drugs mainly can be used even for those harmful practices. But when we speak of medicines purely, these are for therapeutic purposes. So what could be the general purposes? Number one, prevention or prophylaxis. Okay. Secondly, diagnostic. This, of course, is true, therapeutic, and curative. And we know that in our context as midwives, when this woman has fallen pregnant, we are so much on them. I know one thing that has been very difficult to trace is the issue of first antenatal visits. This indicator is poorly performed. But if we had this opportunity of bringing in these women as earlier as possible, then the prophylactic use or purpose of medicines can even be so much emphasized on. We know in the first trimester, we are not giving them antimalarials, but second trimester going upwards, we are giving them antimalarials to just prevent the malaria itself. Secondly, we want to prevent any forms of anemia, so we are giving them the ferrous or the hematinic so that they keep their blood stores, the iron stores, up to the optimal levels, because we know, I think, from the physiology that we could have been doing, there is hemodilution, there is all this that is happening in the cardiovascular system. And we want to ensure that this is not affecting our mother. So some of these purposes, we cannot get all of them, but we can get some. Now, when we come to the storage of our drugs, an inspector for our council, the Nursing and Midwifery Council of Zambia. So one thing that I've noticed is that when you go sometimes for this inspection, the way we keep our drugs, it really we really need to do a lot. The labeling of these drugs, it's so just unpleasant. Okay, and you can't even know whether these tablets are expired or not, because ideally, if you have these patients inpatient admitted, all of them, they will have this drug chart or drug card with prescriptions, and I know you would go to these pharmacies dispensing these drugs and you keep them in this container. But what is critical is that we need to have clear labels, okay? Clear labels indicating the expiry date and so on. For obvious reasons, we do not want to give expired drugs to our patients. Keep drugs on the emergency trolley. And this should be updated as a second one regularly. I know in our labor wards, every labor ward, for you to be so efficient, we need to have an emergency box. Here, back home, I think we have a practice, they call it PPH box, they'll call it this box and so on. They have everything in that box, and every morning there's someone who is going there to just ensure that it is updated. That's good practice. So store drugs in a cool, dry place away from direct sunlight to preserve drug potency. But I don't know why you would find that even these drug cupboards, they are placed near windows. Okay, it's near a window, there's sunlight that is coming through, and at the end of the day, yes, you are administering this drug, but at the end of it all, the potency, the power that it has may just reduce. Drugs that require refrigeration should be kept in a refrigerator, and we know that we have special refrigerators We have special refrigerators, and these special refrigerators are very important. One, I think they could be run on solar. Others, I have seen they are running on kerosene in rural areas. Others are powered by electricity. Now, besides this, drugs should not be transferred from one bottle to another, okay, from one container to the other, right? Apart from that one, the medicine cupboard should not be used for any purposes. Okay, this is a nurse, she's eating food and she finds it easier to go and store food in the medicine cupboard. Drugs should be kept in different cupboards according to the time of use, right? Drugs are stored in a specially designated secure area. Our drug should not be a source of people knocking off. They are knocking off, and I don't know. Some of us, when you check back home, you would find a lot of drugs. Did you buy those drugs? No, you didn't. How did they find themselves these drugs at home? You have a small pharmacy dispensing, even fluids are everywhere at home. Meanwhile, there is someone there who is dying. So drugs should be stored in a secured place, lock and key. Avoid contamination or deterioration of these drugs. Avoid disfiguration of labels. This, if you are using strapping to label, better do it weekly so that the labels are intact and the labels cannot even be faded away. Maintain integrity of packing and so guarantee quality and potency. Then how do we reduce pufferage, theft, or losses? This can also be enhanced. But again, I know it's not allowed for us to have cameras in the labor ward and so on. But how can we ensure that this is prevented? Just be on a lookout. If you have been given an opportunity to serve as an in charge, some of these things should be lockable. Prevent infestation of pests and vermin. This at times is common. This is why people are keeping drugs, but you look around, there are cockroaches passing, and you would wonder, is it possible that these drugs would be potent? This cockroach that went into a toilet comes through again, it is feasting on the same tablets. Okay, then what is now should be the environment where we are storing these drugs? Adequate temperature, sufficient lighting, clean conditions, humidity control. It should not be dumpy, should not be so dry, and so on. Cold storage facilities should be functional and they should be working. If your drugs are put on shelves, they should be adequate, adequate shelves, because anything that would easily see, it is something that can easily be used. So adequate shelving should be ensured. Drugs at every time should be put in a dry place. I think this is an emphasis away from light and away from extreme sources of heat. And then those that are in form of liquids should be put above pallets. Don't put a drug in contact with the floor. Every time it should be above. Okay, and where these drugs are being stored, it should be extremely clean daily, mopped at least once a week, if possible. Now, when it comes to arranging of drugs, if possible, it is expected that these shops should be of steel or rather treated wood. It should be strong enough. And drugs, if possible, if you want to be so systematic and smart, they should be arranged in alphabet order of generic names. Okay, each dosage form of drug is arranged in separate and distinct areas. So we need also to ensure that those drugs recently received should be placed behind old stock. Okay, and this is FIFO technique. Drug that you have received, drug that you received later should be utilized before you use this new stock. And why? It's just to avoid the irrational use of drugs We have seen instances, countries banning a lot of drugs because they have expired. And at the same time, we have communities who are not accessing these drugs. That is irrational. It's also immoral. So practice first in, first out. So FIF4, this one. First in, first out. A good principle to practice. Even at home, I think. First in, first out. It's also important to ensure that I think this we have already indicated that we keep our environments clean. Now, I just want to speak to one issue, and let me just check back on you. Are we clear up to this end? Are we clear up to this end? Are we clear? Anita, are you clear? Marie?
Yes, it is clear.
Julia?
It's clear, Doc.
Now, just a question. Last time you told me you are the four of you. Where is the fourth person?
Sorry?
Where is the fourth person? I'm told this is a class of 4 people. Where is the fourth person?
Yes, we are four. But the fourth, I don't know why she's not available today.
Okay. All right.
She
Let's.
doesn't communicate.
Yeah, Melissa, it's important to communicate since we have a WhatsApp group. Even if I echo, we can still, I think, easily communicate. So even as we are winding up, let me just talk to this issue, which is so related to drug administration, pharmacokinetics. Last week we had mentioned a little thing about this, but in simpler terms, pharmacokinetics is just a branch of pharmacology that is helping us study what this your body, my body, the body of our mother, the body of this newborn baby, okay, we do to this drug once it has been administered, okay. So it's all about the absorption, how it is distributed, how it is metabolized, and how it is excreted, right? And this is summarized at ADME, ADME, okay? So absorption, how the drug enters the bloodstream from the site of administration. And we know some drugs are taken orally, so how will this drug be absorbed? Secondly, distribution, how the drug spreads throughout the body tissues and fluids, okay? That is distribution. When we come to metabolism, and this is all about biotransformation, how the body chemically alters or changes the drug. And this at times mainly it is being done in the liver. Okay, so the metabolism of this drug. Excretion is how this drug and its metabolites, okay, are eliminated from the body, and we know that this is mainly through the kidneys, and this should be the urine. That's why when someone who has been taking this drug, they go to the toilet, they will definitely notice that their urine is smelling the same drug, okay? And at times it could be through the bowel that would be excreted as a stool, okay? The color at times would change and so on. So this is pharmacokinetics. Why is pharmacokinetics very important? It gives us a fundamental understanding of the characteristics surrounding this particular drug. Okay, its effectiveness is mainly determined by pharmacokinetic processes. So hence, very important for us to understand. And by the way, this also gives us an insight as to why some of these drugs cannot be given in large doses, and some of these drugs are given in smaller doses, but they have increased potency. So critical. And I also want to say that remember last time we were talking about half-life, okay? Half-life. This speaks to the issue of the frequency of drugs. For example, some drugs would be given once daily, others it would be maybe every after 8 hours, others it is 12 hourly. And this also gives us an understanding as to why we need to give this medication at the correct time in a more consistent manner. Remember, one discussion that we'll be having is the family planning. I would give you a very good example. This of our mother, this mother is coming to you, and after counseling her and so on, she gives you a hint to say, I want to take oral contraceptive pills. So once she has started taking oral contraceptive pills, it is expected that she should be taking these oral contraceptive pills at the same time. If she decides she needs to be taking these oral contraceptive pills at 7 hours, it should be 7 hours. If she decides she needs to be taking at 01, it should be 01. Why? Because the half-life of these contraceptives, these hormones, synthetic hormones she's taking, is approximately 24 hours. But in a situation where this woman today takes at 7, tomorrow she'll take these contraceptives at 12 hours, the following day she takes at 15, this woman will conceive. Why is she going to conceive? Because the concentration of these hormones in the body that she's taking is varying. And at the end of the day, we have pregnancy, an intended pregnancy that comes through. So pharmacokinetics is trying to speak to these issues, okay? It's trying to speak to these issues, and hence the differences in the dosages, one, the differences in the frequency, that's the second thing. So hopefully that becomes clear. So these drugs, there are so many routes, and I know you being experienced midwives, nurses, we know so many routes that we can administer these drugs. We can administer drugs orally, sublingually, under the tongue, okay, rectally, especially in children, a child is convulsing, that could be a possible route. Apart from that one, intravenously, this is very, very common in our practice as midwives. Intrathecal, okay, this again becomes so important through the spinal cord. Intramuscularly, very important. And this is one thing that we usually use when this woman has just delivered. Subcutaneously, this can also be done. At times, we need to give tetanus vaccines, so subcutaneously becomes important. Inhalation, this can also be done. And in some contexts, we would find oxygen being considered as a drug because of its therapeutic properties, so inhalation, and so on. So topical applications can be applied on the eye, intravaginal, intranasal, the skin, the drug patches. Okay, so all these are ways these drugs can be administered. When we come to drug absorption, okay, this is basically the transfer of a drug from its site of administration to the bloodstream. So that is drug absorption. So if a drug has been absorbed, this is what has just been happening. It has moved from the site of administration, it has found itself in the bloodstream. Okay, Now, the rate and efficiency of absorption will depend on the route that you have used. And I know that all of us, we understand that for IV delivery, actually, intravenously, there is quicker absorption. Why? Because you are introducing this drug already in the bloodstream. Okay, so absorption is complete. There is nothing like this absorption has not been complete because of intestinal juices and so on. So other routes, I think the absorption is more slower than the IV route. Okay, and therefore becomes so important. Now, the other thing that we also need to speak to when we're discussing pharmacokinetics, it's the issue of the lipids or the lipids. Why? Because this become like a vehicle to which some of these drugs will attach even as they move around our bodies, and hence I think this becoming so critical. And apart from this, it is also critical for us also to understand that at times for us to enhance the absorption of some of these drugs, they need to be administered with another drug. And these issues now would speak to the issue of synergism and so on, additiveness. You add this drug with this drug combined together, will have more effect. And when again we come to the other components of what we are studying, we need to end at 20. We have about 13 minutes to go. So physical factors may arise that will influence this absorption. Number one, blood flow to the absorption site. So this just speaks to this issue of blood flow to the intestine is much greater than the flow to the stomach. Thus, absorption from the intestine is more favored over that from the stomach. And usually, when we are discussing the issue of the intestine, it's a smaller intestine. That's where there's a lot of absorption. That's where there's a lot of absorption happening. Okay, so stomach lesser, but intestines well absorbed. Reason there is a lot of extensive, a large network of absorption sites compared to the stomach. One is the stomach contains hydrochloric acid, it also contains pepsin and other substances which may hinder the absorption itself. So the issue of the total surface area available for absorption is what I was just trying to explain. And there is an issue of the microvilli being so extensive and so on, which cannot be comparable to the stomach. So contact time at the absorption surface may also be an issue, especially for drugs that are topically being applied. So the contact time, very important. Now, the bioavailability is the fraction of administered drug that reaches the systemic circulation. And this is expressed as a fraction of administered drug that gains access to the systemic circulation. Yep. So sometimes someone will say, for example, if 100 milligrams of a drug, okay, is administered orally, and a 70 milligrams of this drug is absorbed, so the bioavailability is approximately 0.7 or 70%. So I think that is important to take note. Okay, what is happening? Oh, okay. Sorry. I think I have a situation. Okay, sorry for that. Something plugged in that was bringing on that. So that's bioavailability. That's what we were just discussing. So it's a percentage of the drug that will be absorbed by the system. All right, that's bioavailability. And again, the factor that will affect bioavailability will also include these ones. The nature of the drug formulation. Is this drug soluble? Is it coming in a form of a solution? Is this drug in a form of a tablet? Is it heavily coated? Okay. Chemical instability of this drug, definitely. My laptop will be switching off very soon. So solubility of the drug, phase pass hepatic metabolism, all these are factors that will determine bioavailability. Drug distribution, of course, is all about the process by which a drug reversibly leaves the bloodstream and enters the interstitium. Now, of course, this will depend on the binding ability of this drug to the plasma proteins. The plasma proteins or the lipids are the ones that would help facilitate movement of this drug. So if, of course, this is not well balancing, then definitely the absorption of this drug may not be achieved as it could be achieved. Okay, so blood flow, I think, is still coming back. Capillary permeability also becomes so important. Okay, and this is another issue that we have already spoken to: binding of drug to plasma proteins. When we speak of metabolism, this is just the biotransformation, the process of ensuring this drug has been worked on, okay, and those components of the drug that may not be required are eliminated, and those components that are useful are utilized by the body. And the sites of drug metabolism, it can happen at the organ level, okay, secondly at the cellular level, and thirdly at the biochemical level. So all these points at which this drug can be metabolized at. Okay, I think the issue of pharmacokinetic model, we can go through them when notes have been shared, and I think it's easier to understand and conceptualize. I am doing this because of the laptop that will be switching off soon. Drug elimination is all about this drug being eliminated after use. And of course, we already said this could be achieved through the kidneys or through as stool, through the gastrointestinal tract as stool. And at which point, at the point of the bile duct connecting to the liver, used, okay, dropped into that point, the hepatic point, and off it goes out as stool. So drug excretion may involve one or more of the following processes: renal, glomerular filtration, which we have already spoken to, the kidneys using it, then biliary excretion. Okay, so this, of course, is what I spoke to from the liver, excreted, the biliary tree goes down to the smaller intestine, and off it is taken out. Then, lastly, even as we come to the conclusion of this discussion, we have control of dangerous acts or control of drugs that are not prescribable. These are drugs that cannot be sold over the counter. These drugs need to be kept in a locker and a key, and these are drugs that could be narcotics such as pethidine, mandrax, marijuana. Of course, we're not using it in Zambia. I don't know in other countries. There have been a lot of push that this becomes identified as medicinal, and I know politicians because it gives them a lot of money. So these drugs are never left on their own, but they need to be under a cupboard and a lock. And these are some of the drugs that we even find in our labor wards. Pethidine, this woman has, for example, yes, I know it can be given in labor ward, but of course, not at the point when this woman is above 5 centimeters dilated or reaching 8 centimeters dilatation. Why is it so? You end up having a baby that is asphyxiated because this pethidine that you have administered will also have an effect on this unborn child. So caution should be taken. Now, this is a drug that should not just be given to any woman. Any woman just over crying, you administer. No. Yes, painkiller should be administered because pain management is one of the golden principles of us caring for these women. We need at all costs to eliminate as much as we can the pain that they are experiencing. But again, for you to reach out to pethidine, then that could not just be pain, but of course, maybe related to malpositioning, OPP, and so on. So, how then should we keep this drug? I think already we said this should be under a lock and they should be ordered from the pharmacy in a requisition book. And every time when you use pethidine, if this is an ampule that has been broken, you should keep it as evidence. We have had situations where nurses become so addicted to pethidine, you walk over in the morning, they have broken a lot of bottles only to satisfy their addiction. You check around which patient was given this pethidine, there is none. So please, this should be taken care of. Then to sum it up all, what we have discussed becomes so important to us, even though we are found in labor ward with just similar drugs. We are not limited to those drugs because these women that would come, they are pregnant, yes, but they would come with a cough. What are you going to administer to them? So even if it's applied pharmacology to midwifery, I urge each one of us to at least read on other drugs that would be of help to these women even as they come to deliver from our facilities. We'll end here. Is there any question? Any questions, colleague? Mary, any question? Annette, Julia?
On my side, everything is clear.
Great, Mary. Annette?
Very clear to me.
Julia, great, Annette.
No questions.
Great. Colleagues, tomorrow I will send things that I supposed to send. Sincere apologies. I know you are good people and you are forgiving, and that's how it should be. So I will share these.
Yes.
Yeah, surely. So I will share these